Hey guys, Jen here. This is a little bit of a big video, so I'm feeling a little bit overwhelmed, but let's do it. As you already know, I get a lot of migraines, and as you probably correctly assumed, I've taken a lot of medications for my migraines. But when my doctor offered me the anti-CGRP drugs, the new ones that just came on the market in 2018, I said no. Hard pass. I think that decision really threw a lot of people off because my migraines are so consistent and there's such a huge impact on my life. But to be honest, I just don't have trust in these new drugs yet, and in this video I want to really go through the details of why I don't. Now, to be clear, I'm definitely not saying that they're not safe. I'm definitely not saying that they're not effective. What I am saying is that they might not be safe. I'm saying that there could be a chance that they're not quite as effective as we all thought they were going to be, and maybe that small amount of effectiveness isn't worth the risks in the long term. Like most of the things that I talk about on my channel, it is a matter of personal preference, and it's a matter of talking to your doctor, really evaluating your life and the impact that migraines have on your life, and deciding whether or not the risks are worth the benefits to you. So let's get into the data. If you are new here, or if you just haven't run into this information yet, I was a biochemist before I got sick. So I am trained in, and I have worked directly in research papers, reading data, and in fact I even had to take a class as part of my degree where we looked at already published papers and tried to nitpick and find holes and find exceptions or places where they were misleading. So I'm very trained in being critical about data. It was my job for almost a decade, and perhaps that put me in a little bit of a different situation than most migraine patients who were considering these drugs. And that's why I sort of feel like I owe it to you guys to try to explain this the best I can, although guys, it's really hard to organize this much information into a YouTube video and make it palatable, so bear with me. This might get a little bit technical, but also keep in mind that this is not my area of expertise. Like, I can read the data and stuff, but at the end of the day, I am not an expert in these drugs. You need to do your own research and trust your gut, trust your doctor. I'm pointing out how I feel, but this is not necessarily how you should feel. I hope I've said that enough. Please don't get me in trouble. First, let's talk about what CGRP even is and how it relates to migraines. CGRP is an acronym for a peptide. A peptide is a protein subunit. CGRP is elevated during migraines and cluster headaches, and in fact, if you infuse CGRP into a person who gets migraines, it can trigger a migraine. Usually the CGRP hangs out outside the blood-brain barrier. It binds to blood vessels to release nitric acid and more CGRP. So this cycle continues, the CGRP continues to increase. A bunch of stuff happens with trigeminal things and ganglia cells, and it mimics neuroinflammation, and the loop continues to happen, and it continues to build up over the 4 to 72 hours of your migraine attack. The theory behind these new medications is that if you block the CGRP molecule with an anti-CGRP drug, or a CGRP antagonist, then it disrupts that cycle and reduces the head pain that happens during that cycle. So these CGRP drugs are actually anti-CGRP drugs. The ones I'm going to be talking about today are the preventative ones. All of the preventative ones that I'm aware of are an injection that you do either once a month or once a quarter, which is every 3 months. And most seem to come in 2 doses, where the high dose is just double the low dose. There are a couple of oral abortive ones too. I don't know anything about those. I'm skipping those for today. The very first one to be FDA approved was Aimovig, and it was approved in May of 2018. A couple of different brands rolled out soon after that. Aimovig got a lot of hype for being the very first drug on the market that was ever developed specifically for the prevention of migraine. And people were also excited because it's a human antibody, so it's less likely to have drug interactions, which is excellent because migraineurs tend to be on a lot of different medications. Anyway, it was a very exciting time for the migraine community. It was a huge win for the disease. And honestly, I know that you're not here to hear all the good things about it. You want to hear why I didn't want to take it. So I'm going to skip the good things. You can look up all of that wonderful press, and I will skip straight to the reasons that I didn't feel comfortable taking it. First things first, these are of course FDA approved drugs, but the FDA isn't perfect. My first job out of college was actually reporting to the FDA. I worked at a medical device company, and my job was literally to take the complaints for our medical devices and to report them to the FDA. And you know, when you're like really deep in something, you learn some things are a little bit weird. I'm not going to share details, but this was no exception. So that's just an inner workings thing for reporting and stuff. But there have also been some pretty high profile examples of drugs that the FDA approved that probably shouldn't have been approved. Like Rezulin, a diabetes drug. It was originally approved, but then post-marketing results showed that it was giving dangerous amounts of liver failure. It was pulled off the UK market in 1997, but the FDA didn't pull it from the US market until 2000. So it is claimed, allegedly, that thousands of people were injured and even killed by this drug being on the market when it shouldn't have been. That's only one example. There have been others. But I wanted to just share one because it's important to realize that the FDA, even though a lot of times they do get it right, they are not perfect, and you can't necessarily blindly trust literally everything that they say. In fact, you shouldn't blindly trust anything anyone says, so don't trust me either. Go do your own research. Now that I have clarified why I'm not just going to trust it based on the fact that it is FDA approved, I'm ready to get into reason number one that I said no to these drugs. The first reason is that if you really dig deep into the studies, the effects appear to be weak. Weak is a subjective term, but what I mean by that is in a lot of the studies that I was seeing, there wasn't really that big of a reduction in migraine days when people were given the drug versus when they were given a placebo. A placebo is when they run the same clinical trial with and without the drug, and you don't know whether or not you're getting the drug, and you have to report back whether or not you're feeling better. So if a lot of people feel good on the drug, but a lot of people also feel good on the placebo, then you can't actually conclude that the drug is doing anything to help. There are ranges in effectiveness, so each set of data is given error bars. So if the effectiveness of the placebo and the effectiveness of the drug are very close together, which is the case for a lot of the data that I was seeing, then we can't be sure that there isn't actually some overlap there, especially when you factor in that the people running the studies, they're not supposed to be biased, but they can be a little bit choosy with data. That's all I'm going to say. Cleverly worded ads can also make the data seem more impressive than it is. So an example from Aimovig's website, I'm reading on my laptop, they said up to half of Aimovig treated patients cut migraine days by at least 50%. Sounds awesome, but a little misleading. If you look at the data, up to half actually meant 43% of the patients on the low dose and 50.0% for those on the high dose. What their catchphrase didn't mention is that almost 27% of the patients on the placebo had the exact same effect. Their claim, although it's correct, is pretty misleading. Up to half of Aimovig treated patients cut migraine days by at least 50%. Okay, yeah, but like how much of that was really due to Aimovig? The study was also done with less than 1,000 people, which isn't a huge sample size, and that's less than 1,000 people divided into the three groups. So there's actually only 300 and something people who are on each of the doses. So the studies I was finding, it's a new drug, so they tend to be small, they tend to be pretty short term, and of course there's going to be exclusionary criteria. Those 300 people are already very narrowed down to people who have a particular number of migraine days per month. They probably don't have comorbidities, they can't be on certain medications, so it's already very narrowed down before we even get to the point where we're at the study. So it's also just not a very diverse representation of the migraine population. So it's probably fair to say that these drugs are in the ballpark of the same effectiveness as the drugs that are already on the market for preventing migraine, but the drugs that are already out there have a lot more safety data available. And even though there is some safety data available for these anti-CGRPs, I'm honestly not all that convinced by it, and in fact I'm a little bit worried by it. A lot of me wants to say any reduction in migraine days is a really good thing. What's the harm? And the answer in my head is always that we don't know what the harm is yet. So that brings us to reason number 2. Reason number 2 is it's not specific. As in, migraines and CGRPs are not loyal to each other in either direction. Migraine doesn't only care about the molecule CGRP. Lots of different things can trigger migraines, including other vasodilators. So we can't expect that blocking just CGRP is going to be enough to be a magic pill for migraines. And on the other side of that is CGRP. It's not loyal to migraine either. We do have some CGRP receptors in our head, but we also have them in all sorts of other places, like, I have to read it, sorry, the central nervous system, the cardiovascular system, respiratory, endocrine, gastrointestinal, immune, thyroid, and they're also active in wound healing and other physiologic functions. That's a lot of things that CGRP is involved in your body. So blocking CGRP to try to block migraines is also blocking CGRP from all of these other systems. So that got me thinking about what are the common adverse effects of taking this medication. And injection site pain was one, of course, but also topping the list were infections like upper respiratory tract infections, urinary tract infections, influenza, constipation, and muscle spasms or muscle cramps. And that's only the most common stuff that was actually showing symptoms within the time frame of the study. And that's 3 really big asterisks. There could have been countless other things going on in their body that just weren't causing any symptoms, or weren't causing any symptoms yet, or the sample size of just over 300 per group, which is pretty small, just wasn't enough to expose some of the other things that could happen. By the way, I'm not trying to just pick on Aimovig. I'm not saying that Aimovig is bad and the other ones are good or whatever, but I sort of just picked one brand and stuck to it, and since Aimovig was the very first one that was released and FDA approved, I figured this is a good one to just, really dig into their website and see what they have published. So I looked at Aimovig's safety study. They did a 1-year safety study. I think there's also a longer one, a 4-year, 4.5 year. I didn't look into that. I stopped at the 1 year, but I thought this 1-year safety study was kind of interesting. Over 1 year, 55 to 57% of participants had an adverse event happen, depending on which dose they were on. And 3.3% had a serious adverse event, regardless of what dose they were on. And I don't know what serious adverse event means, but that's a lot. Also, 1 person on the high dose died. That's not a very good rate of living for a study with only like 500 people in it. And what's concerning about that within 1 year is if this drug works, you end up taking it for decades. At this point, we don't know if effects like this are cumulative, so the drug got FDA approved, and then the post-marketing results showed that people were developing hypersensitivity, constipation that sometimes required surgery, and hypertension, which is high blood pressure. So there are clearly some things happening in other body systems that we just don't understand the full mechanism of yet. And as I mentioned before, there's probably even more happening that just isn't causing symptoms. Related to that, we don't know enough about blocking CGRP to know whether or not the important roles that CGRP is playing in all of the other body systems is being made up for somehow by other molecules. I think the best way to hammer that point home is with a couple of examples. So, digestion. When you eat, there are enzymes in your mouth and enzymes in your stomach and other digestive stuff that all work together to digest the food that you eat. If you were to block one of your digestive enzymes, like let's say you totally bypass your mouth, you swallow a pill whole, the other enzymes and things are able to make up for that lack of this enzyme and you can still digest the pill fine. That's proven safe. It doesn't do anything. It's not going to cause you any harm. Let's say, for the sake of this example, that insulin is found to play an important role in migraines. A new drug comes out, we block insulin, we block the migraines. Heck yeah, sounds good, this is great. But insulin has another very important role in the body, regulating your blood sugar. Insulin is completely irreplaceable for regulating your blood sugar. If you have issues with insulin production or insulin getting blocked, over time it can cascade into a lot of horrible symptoms. It can be very dangerous for you, and you really don't want to do that. However, at the very beginning of your diabetes journey, it can start out very mild, it can start out very non-specific. And I hope you guys see the parallel that I'm trying to make here. If we have CGRP receptors in all sorts of different places in our bodies, do we know whether CGRP is actually crucial to any of those systems in the way that insulin is crucial to blood sugar regulation? And I'm afraid I can't really find an answer to that. And we certainly don't seem to have the research out now to say that blocking it for many decades is safe. Which is my reason number 3. My reason number 3, the last factor that I'm really considering here, is time. People who have good results on this medication are likely to stay on it for a very long time. And in my humble opinion, my novice opinion, we can't really know the effects of doing this for a long time until a lot of people block this molecule for a very long time. If the side effects in shorter trials are constipation and infections and arthritis, and especially if we don't know why that's the case, then I don't want to use my body to test what happens after 20 or 30 years, even if it meant that I didn't have another migraine guaranteed for the rest of my life. And I actually found a 2018 paper by Robbins and someone else I'm not going to try to pronounce the name of, and they suggested that the use of this family of drugs should be limited in people who are under 30, precisely because the long-term effects are not understood. An example of one thing that isn't too far-fetched, we know that CGRP is a vasodilator, and it's shown to have some protective role in preventing heart attack and stroke. A 2018 study by Key and others said that blocking CGRP might block the protective role that it plays in preventing heart attack and stroke. Given that small stroke-like lesions are already more common in people with migraine, it seems like it could become a long-term issue to block a molecule that plays a protective role in stroke in these patients. Along the same lines, and also in 2018, Loader and Birch published a paper talking about who should be considered for these new antibody migraine drugs, and they said that the drugs should be avoided in any patients who have an increased risk of stroke or coronary artery disease. So, problem number 1, patients who have migraine with aura are already at an increased risk of stroke and coronary artery disease. So, are we just ignoring that connection exists? I'm wondering if in the safety studies were migraine with aura patients just bunched in with the not migraine with aura patients, because it seems like this would be a really important thing to investigate. Also, problem number 2, let's say my migraines weren't aura, I'm just a normal low risk for stroke and coronary artery disease now. What if in like 30 years I'm going to become a risk for stroke and coronary artery disease? I don't know yet, you know? And what if blocking the protective role of CGRP makes it so that in 10 or 20 years I become a higher risk for stroke or coronary artery disease instead of the hypothetical 30 years that I have now? I don't know if that could happen. I don't know if anybody knows if that could happen. The drug itself could, in theory, increase my risk if CGRP really is protective. And actually, it was found that if you infuse mice who have heart disease with CGRP, their circulation does improve. So what if that's happening all the time in me right now, even though I don't have heart disease? I don't think it's that far-fetched to say that it could be doing some prevention stuff. There, I said it. Do your own research, but I don't think that I'm that far off the deep end with that. Another potential long-term problem that I don't think is that out there is hyperalgesia. Hyperalgesia is when your pain receptors become hypersensitive to pain over time. And right now it's talked about mostly in terms of opioids. There are a lot of medical professionals who believe that if you take opioids for too long, your pain receptors become more receptive to pain, which then makes it harder for you to get off your opioids. Since CGRP is a molecule that's involved in a pain transmission pathway, it's been suggested that long-term use of a CGRP blocking drug could have similar effects to being on an opioid for a very long time. Nerves could become hypersensitive. And if you recall just a little bit ago, I mentioned that the Aimovig post-marketing study had patients reporting hypersensitivity. So, sounds like a lot of conjecture, but it's again, like, it's a strong maybe. It's all got me thinking if you just pile all this stuff together. I want to give you one more example of a long-term thing that could happen that's, again, another maybe, but I found it kind of interesting. I need my laptop for this one because my brain. Right now, there is not evidence of liver toxicity with use of the anti-CGRP drugs. However, CGRP drugs of the past have induced some liver toxicity. This paper was published in April of 2018. It's on PubMed, it's on NCBI, so it's a scholarly article, and it's about targeted CGRP small molecule antagonists for acute migraine. So this might be the same as the oral ones that I mentioned earlier, that like the oral abortive one, but I found this a little bit concerning for me just because I tend to play it on the really safe side. In the abstract it says that the majority of the clinical trials conducted have proven positive, demonstrating the importance of this signaling pathway in migraine, which we already know. By now, or in the future, we know that this can give us good results for preventing migraine. However, it also says, unfortunately, a number of these molecules raised liver toxicity concerns when used daily for as little as 7 days, resulting in their discontinuation. Despite the clear safety concerns, clinical trial data suggests that their intermittent use remains a viable and safe alternative, with 2 molecules remaining in clinical development. And they mentioned 2 compounds by name. One of them is Ubrelvy, that was still in development, and the other one is Nurtec. Ubrelvy and Nurtec are both acute migraine treatments that you take like a triptan. You take it at onset. And I don't think it's that crazy to say that if you have liver toxicity concerns for acute treatment in as little as 7 days, then it's possible monthly treatment over 30 years might also cause some liver toxicity. So I realize at this point I'm being a little bit concerned about my head, I'm being a little bit concerned about my heart, I'm being a little bit concerned about my liver. So I'm thinking, okay, maybe I should trust the FDA, trust the doctors. Maybe I'm being a little bit of a hypochondriac here, until I ran into something crazy. You know who else is concerned about these exact things? The freaking FDA, guys! The FDA wrote the manufacturer of Aimovig saying that they want post-marketing surveillance on liver toxicity, heart attack, and stroke. Meaning, go ahead, it's approved, go, prescribe it, have people take it, but later on, let us know if these 3 things end up being a problem. And I really don't know how I feel about that. Because the argument on one side is all these people are able to be helped now. A lot of people are getting their life back and they feel so thankful that they found this drug and they get to be borderline cured from it. Like, I've heard some really, really great success stories from CGRPs. On the other hand, I'm wondering how many people take the FDA approval as all of this has already been looked into, and so we can trust these drugs wholly, and the chances of a recall are low. Does any of this mean anything concrete? No, absolutely not. And I guess the short answer to this whole entire question is that that's exactly what my problem is. No amount of migraine reduction is worth potentially increasing my risk of all of those. There's my answer. I'd love to hear in the comments where you stand, whether you're on these drugs already, just considering it, whether any of this information was surprising to you or changed your mind. Like, please do chime in. I'm worried that this is a little bit of a controversial video, even though I'm trying to be very clear that it's all really wishy-washy to me, and I'm just choosing to play it safe for myself. Really important for me to reiterate again, the choice that I make for me isn't necessarily the right choice for you. You have to do your own research and talk to your doctor. And if these drugs seem like they're gonna help you, or if they're helping you already, by all means, go for it. They are FDA approved drugs. They're on the market. They are there for people to enjoy them and reap the benefits of. And if they are giving you your life back or giving you days back, that could 100% be worth it to you. As for me, I am going to wait until next lifetime when there have been lifetime studies on it, or maybe when I'm like 60, maybe in like 30 years there will be 20, 30-year trials and I won't need to worry so much about the long-term effects. Maybe at that point, if I'm still getting migraines, I'd consider it again. But for me, it's just not for right now. And that's okay. That's my chair. I'm not farting, it's my chair. Anyway, if you have made it all the way to here, you are a warrior. You have no idea how many studies I read for this video. I read so many papers and did so many iterations of what I wanted to tell you guys, and there is so much more out there, but I hope you learned something. I hope I presented it in a way that was understandable to you. I hope that it made sense. I hope I did it justice, and I'm pooped. It's pregnant nap time. I will see you guys with another video next Friday.